All right, good afternoon. Welcome to the only all-woman powered healthcare session. Yes, it's okay, you can clap. You can clap. My name is Erin Albert. I am a pharmacist at Mark Cuban Cost Plus Drugs. I'm based here in Fishers, Indiana myself. Today I'll be your moderator. It's my understanding we're just going to have a chat for about 45 minutes with these three incredible women leaders in innovation in healthcare. I'm going to have each of them introduce themselves. Right now at Mark Cuban Cost Plus, I work on building what we call the Team Cuban Card, which is our affiliated pharmacy network of thousands of pharmacies across the U.S., where we bring our transparent pricing along with your ability to work with your local retail pharmacy and keep your prescriptions near and dear to home. So with that, I'm going to start here at my left, and each of these incredible women are going to introduce themselves.
Hello, I'm Ethel Massing. I'm from Fort Wayne, Indiana. I am the Director of Innovation and Strategic Enterprises for Parkview Health. Parkview is the second largest not-for-profit health system here in Indiana. I'm also the CEO of our startup spin-off company called Safe Sleep Simulation. Obviously at Parkview Health we do what other health systems do, but on the innovation side I'm really about bringing in transformational care, bringing in outside technologies, and trying to help companies in the way we can and help transform care for our patients.
Hello, good afternoon. My name is Dr. Cami Wright, and I am Chief Medical Officer of CareSource here in Indiana. If you're not familiar, CareSource is one of the managed care entities. We serve primarily Medicaid members. We also have a very large marketplace population as well. So the majority of the members that we care for are those who are at most need for healthcare services and care coordination. Happy to be with you today.
My name is Elizabeth Hagerman. I'm the Chief Innovation Officer at UW Health in Madison, Wisconsin. And in my group, we focus on helping innovators within our health system commercialize new healthcare technologies. And we also offer investment in early startups that are aligned with our health system.
Great. Well, thank you, ladies, for introducing yourselves. I want to give a shout out really quickly to Kristen Eilenberg, and I don't see her. Oh, there she is. She's the mastermind behind this panel, so thank you, Kristen. And Kristen did a phenomenal job of getting us together before today's talk to just have a discussion about what we're actually going to talk about today. And so the first question that I want to throw out that was always top of mind with all of us is, ladies, what's keeping you up at night in your roles respectively? You all come from different points of view, so I'm going to start down at the end and work this way.
All right. So I'll answer this two ways. For our health system, the number one topic on everyone's mind is access, and the numbers are really stunning. So if you go back to 2019, we were mostly able to care for the patients that were coming to us. And over the last 4 years, we are doing more, serving more patients. We've become more efficient, and yet we have longer waits than ever. Access is more of a challenge than ever. And that presents a lot of angst within the system because the providers are performing better than ever when you look at the metrics, and there is more need than ever. So that's one major focus of the health system, keeping lots of people up at night. And then for my own group, focusing on supporting the innovators in the healthcare space, I think the challenges for healthcare startups are also increasing over time. It's not enough just to get your 510K clearance or just to talk about your value proposition. There's a higher burden of data needed. There is more proof of pilot, proof of concept than ever before that's required to really break into a health system. So we're constantly thinking about how to help innovators overcome those barriers that are getting harder and higher all the time.
So I think what keeps me up at night is very similar to your first point. And it is sub-optimization of using healthcare services. So what we find with our members is that since the pandemic, where people were reluctant to engage in the healthcare system, we now have 30 to 40% more utilization than we had just a few years ago. So what that means is that there are more people trying to access care, and that ability to access care may be limited by several different things that I think that we'll talk about a little bit later. I also think that there are opportunities to make sure that people are accessing the right care at the right time in the right location. So we have overutilization of urgent care and ED facilities, and underutilization of the doctor's office, which is where we really want people to be getting care. We want people to come in, have a medical home, have a relationship with a provider, and really have that preventative health care and screening that might help to stave off problems in the future. So really trying to make sure that our members are getting the right care at the right time in the right place is one of the things that keeps me up at night. And the second thing that's related is health equity. So we know that there are certain populations that have even a greater issue with accessing care, either because of their perception of maltreatment, either because they are at a geographic location where there are not enough facilities, or perhaps English is not their first language, and so they have just an inherent difficulty understanding the healthcare system and understanding the advice and the information that's being provided to them. So I think in addition to getting the right care at the right time in the right place, we also want the right environment and the right experience for patients. And so those are things that I find to be particularly challenging right now.
I'm in the same place I was in the prep call, where I just want to say ditto. So we have a health system, we have the very same challenges. What keeps us up at night in general is access. We are opening more facilities than ever, and every facility we open is full. During the pandemic, we accelerated building of a new tower, thinking this will give us room to grow for a couple years, and it has been full since we opened it, and there's no chance of slowing down. And so how can we get patients in quicker to the places that they need to be? Because obviously they want to see a doctor, which is great. They want to use the health system. It's not a bad problem to have, but it is tricky to get them where they need to be seen in the time that they want to be seen. And especially in a space where we continue to have more and more competitors. There's a lot more B2B, if you'd say. Patients have a lot more choice than ever before, but it means they're getting a lot more fragmented care than ever before. And so that keeps it being a challenging place. I think on the personal work side, access is another issue. And it's a great problem. There are so many companies with so many great new technologies and ideas and AI products that they all want to work with us. They all have great projects to do, and we can't do them all. So really trying to figure out what are the places that we can best help? What are the best technologies that we can bring in for our patients? And really figuring out how to do the best evaluation of those and which projects we should really do that. That keeps me up a lot of nights.
Well, that's a kind of great segue into, I guess, my next series of questions. I'm going to go down to the end again with Elizabeth. So let's say hypothetically, this is about innovation, right? And startups engaging with larger organizations. So if you all had advice on how, when you work with larger organizations, how those startups can correctly engage with your organizations to bring those innovations to you, and if you have any advice for those people with startups in the audience, what that looks like.
Yeah. I think, like I was alluding to before, it's harder and harder to become a vendor in a health system for all the reasons Ethel just said. Everybody wants to be a partner, which is great, and then we have the burden of figuring out who can serve our needs, who is real, who is half-developed versus fully developed. And so my advice to innovators and startup companies is to be very clear about not just your value proposition, what you think you can do for the healthcare system, but also how you'll do it and what parts of their organization do you realistically need to help you achieve this goal? Because I think that's another misconception. The vendor thinks they're going to come, deliver the product, end of story, and usually there is lots, especially in the digital space, or if we're talking about an AI solution, there is lots of integration that has to take place. There might be adjustment of workflow, not to mention just psychological buy-in or adoption of a new technology. So I think it's important for the startup company to come in recognizing that those are all additional hurdles, not just technological hurdles. Come in knowing that, and then be able to offer support structures, be willing to be flexible about how you might work with the hospital. Some are going to want co-development agreements, some are going to want to just do a pilot at no cost. There's all these different constructs we can think about. And then, unfortunately, I do think you have to set your sights realistically on timing. Health systems are large and complex. Even if you're a small health system, I would say they're still large and complex organizations to navigate. So the timing will take longer and be more expensive to achieve your goal of working with that health system than probably you want it to be. So thinking about just the runway of the business is an important factor, as you're planning these long rollout strategies.
Any other thoughts, ladies?
I have some thoughts, just a different perspective. Very similar engagement with vendors. I'm approached via email or in some other form by vendors on a daily basis. And I think that what's really critical is to distinguish yourselves from the other competitors. So oftentimes I get emails that seem very, very similar with very standard language about some solution or product. I would encourage entrepreneurs to really figure out what makes your product different, and how you can really put that at the forefront so that you don't look like a me too, and you can grab the attention of the key stakeholders. So I think that's really important. And I think it's also really important to tailor your message to the person that you are addressing. And that seems obvious, but I think that really understanding what the need is of the entity, whether it's a hospital or a payer, and what they might need today and what they might need in the future. So we are very highly regulated. We are constantly being told what to do by the state and by CMS and by other entities. So if a vendor can come to me and say, hey, CMS has this final rule that we anticipate, and you are going to need X, and here is how I can solution for that, that really resonates with me. So saying what's different and really meeting the need of the person that you're speaking to, I think is critically important.
Yeah, so I think one of the things we were just saying before we came out is that as far as even innovation within healthcare, every innovation department you meet with a healthcare system is going to be different and do different things. So I think as a startup company, the first thing you have to do is figure out where to put your foot in the door, and sometimes that's difficult. Sometimes it's innovation, sometimes it might be digital health, sometimes it might be IT. So figuring out where that first place is, and then when you get to the right person, make them your partner and really work together with them and listen to them. We're not telling you things to make you mad or spend more money. We're really trying to help you. When you work with us, we're your champion and we want to help you along. I think a key point is talking about how you differentiate yourself, and I think that part of telling your story, be really clear about what you do and explain that. We're all in healthcare. We know what the problem is. I've sat in pitches where we're 25 minutes in and they're still telling the problem. It's like, I'm in healthcare. I understand that diabetes is a problem 24 minutes ago, 24 and a half minutes ago. So, you have to understand, think about your time and be really clear about, show us what you have, show us what you do, and be really clear about what you need. And then, like you said before, about being flexible. When you come in and ask, implement this in all your hospitals, and we just need to integrate it, it won't take that long. That's a big, tall ask. So what's the smallest piece that you can do that can still give you a really good outcome. And let's put the foot in the door there and show a good outcome, and then we can talk about next steps.
Can I offer another one
Sure.
as well? That reminded me, there is always value in talking up your product and good salesmanship, but my other piece of advice is be honest. Yes. Because what sometimes happens is you'll hear a vendor say, oh, we're working with this and this and this system, and then we'll go check because we probably have colleagues, in those systems, and the truth maybe is different than what was represented, and that's a fast way to go low on the priority list, I would say.
Yeah.
Transparency is always a good word in
yeah.
healthcare. Yeah. I'm like fangirling over here because there's so many directions we can take this conversation, and we're going to put a pin in AI because we're going to come back to that. But I want to go back to access because I know that's a huge challenge for all of your institutions. I'm going to pick on Dr. Cami here.
Yes, please.
Can you share some wins maybe in your organizations trying to bust those barriers, thinking of English as a second language, or even just getting to a primary care provider? What items are CareSource, for example, working on to take that innovation and drill it into easier access?
Yeah, great question. Thank you. I think that we need to envision the healthcare system in a broader way. So my colleagues from the hospital side have explained that doctors are working as hard as they possibly can. But unfortunately, there are only 24 hours in the day, and going to the doctor's office cannot be the only site of care. So we really need to broaden where people access care. And I think that this is a space where technology and innovation have had great wins, and I think there's still great opportunity. So one thing that jumps out in my mind is telemedicine. So telemedicine had a moment during the pandemic, and the pandemic really pushed that forward a lot more aggressively than perhaps it would have been without the pandemic. And so we use a telemedicine vendor that allows our members to get care 24 hours a day from the comfort of their home. Part and parcel with that are digital apps. So we have multiple digital apps, some of which have either a synchronous or an asynchronous component to it, where you can speak to a provider, get healthcare advice, or have questions answered. I think that this is really important because people need to have options. So maybe getting into their doctor is not the right choice, or is not feasible, or they work third shift, or there's some other barrier. But can they use the solution that we all carry in our pockets to help access care? I think that that's really, really important, and I think that that has been a great innovation. I think one thing that started out great but hasn't quite met the need is the electronic health record. So, I'm old enough that I practiced when EMRs and EHRs first became adopted. And the goal was purported to be that you could go anywhere in the world and someone could access your healthcare record. Many years later, we're still not quite there. And I use this analogy in our conversation, and I use it often. The financial world has figured it out, right? So you can be in Europe, and you can be in Africa, and you can be in America, and you can go to any ATM, and in real time, it knows your financial data, and you can get money out. Why can we not do the same thing in healthcare? You should be able to go anywhere in the world, and there should be a secure way to access your healthcare records. I don't know why we haven't been able to do that. I hear privacy cited as an issue, but what's more private than your financial data, right? So if the financial industry has figured it out, why can't we figure it out? I think that's where we need to morph to. And I don't know if this is an opportunity for blockchain or some other sort of data element, but I would love for some entrepreneur to figure out how we make healthcare records more portable, more accessible, how we leverage our phone in a secure way so that you can dock in or some sort of way anywhere in the world and have seamless healthcare. Those are some things that kind of jump out to me. AI, obviously, hugely important and lots of potential, and I suspect we'll get to that a little later.
Anything else, ladies?
Yeah. So when we think about access, we really think about trying to supercharge our physicians. There are places where we definitely cannot replace physicians and where we definitely need physicians. And thinking about in the procedure room, so you're thinking GI, and we need them in the endoscopy suite. But where are places where we can use technologies or even people to supercharge physicians to get them where we need to be? So things like using generative AI and ambient listening so that physicians can spend less time writing notes. We use a lot of APPs in our practice, so these are advanced practicing providers, to do follow-up visits. So again, we can keep providers in the highest level where we really need them to be. Utilizing virtual care. So we had really ramped up virtual care, thankfully, before the pandemic. And this really allows our physicians, as they're seeing patients in the office, somebody doesn't show up, they can quickly grab another visit in that queue and really keep processing patients quickly. Another place is on the nursing side. So we obviously need nurses at the bedside, but there are things that the nurses do that don't have to be done by a nurse at the bedside. So we utilize a lot of virtual nursing. We're in virtual ICUs. So we have nurses that sit in a virtual care center that can visit patients. They can give discharge instructions and education and answer questions. Some of those things that take away from what a bedside nurse has to do so that she can keep going around and seeing patients and helping them with things that they need. And so really, again, helping supercharge the people that we do have at the bedside utilizing other technologies.
That made me think of one other really great advancement that we use, and I know other places use this too, is remote patient monitoring. So I am an OBGYN by training, very, very concerned about care for women and infants. As I'm sure everyone here knows, we have a problem with infant and maternal mortality in this country. And I think that there is an opportunity to really push the envelope in terms of remote patient monitoring, wearables, things of that nature that could be used in many different settings, but I'm thinking particularly in that maternal health setting, so that we understand what's going on with the mom and the baby and the physiology of the pregnancy, not only while she's in the office, but outside of the office as well. I know that there's some great companies like Navigate Maternity, for example, that are doing that. And I think that we certainly have adopted RPM for many different conditions, but not yet pregnancy. I would love to see more innovation in that space.
I was just going to say ditto to those. So we had some examples with remote patient monitoring for postnatal blood pressure monitoring, excuse me. And exactly what you're talking about, it's a simple solution, and we've had great success with it, but there was lots of integration to consider, and then we're in the position to say, okay, do we end it there or push the envelope? How much further could you take it? And those examples are also interesting on an economic basis, because the hospital does have to invest in the solution, which, invest to make more is, kind of the philosophy there. But you are in a position to take the risk, invest in the beginning, get your remote patient monitoring vendor, get the integration done, then see the results. And in these cases, like you're citing, and it happened to us too, it reduces readmission, the patients are happier, they're more likely to, offer data than they would otherwise, so the care ends up being better. And largely because of the reduced readmissions, it's a financial win for the hospital. But all that takes time and money to play out. And then maybe an extension of that to mention, extension of remote patient monitoring is hospital at home. So that's another buzzword in the field, which is promising. And I think the economics of why that's promising is also interesting. So at least in our system, hospital at home does save money, but only when there are big access issues. So it's the people who are enjoying that service really are enjoying it, and I think they're getting great care, but it's another one of those kind of shifting situations where that became a valuable asset. Hospital at home operations became a valuable asset because the inpatient setting was, so hard to access, so overcrowded, all those things.
Yeah.
Well, I was to say, I think you bring up an interesting point about saving money, because one of the things we've seen an explosion of is people coming in with remote patient monitoring solutions. And a lot of people have done that because now there are codes for remote patient monitoring. And so everybody thinks, oh, well, this is great for you. You can make money doing it. The reality of it is the reimbursement of RPM is very low. The amount that you're actually going to get from those codes is very low, and the cost of the person you have to pay to collect that and do the work and watch the data can be very high. And so there often isn't a great ROI. So as you're, there are a lot of innovators out there. So as you're looking for solutions, you have to really think about, it's not just about the code. What's the total ROI of your product, and how much money is the hospital going to have to spend to actually get that small amount of reimbursement?
I think that's a great point, and that brings up a larger topic that might be out of our scope, but value-based care, right? So I think if you're looking at ROI simply in a small way, like, what am I seeing in my congestive heart failure patients, then that ROI might be small. But if you start to have contracts with payers where, there's a financial incentive to have healthier outcomes for an entire population, then the math may work out. And so that is another, I think, opportunity, is looking at innovation in terms of payment arrangements and payment methods. And how do we make it make sense for incorporation of these new technologies. And when we're talking to vendors, we also have conversations about value-based care. I think the previous model of paying on a PMPM basis, which is per member per month, like per click basis, is really fallen out of favor. If you come to us with a solution, we want some shared risk there. And so, we're much more interested in figuring out how we incorporate value and quality into payment arrangements. So that probably would be another piece of advice that I would give to entrepreneurs, is think about innovation in that payment arena.
Whole time, you don't have to participate if you don't want to. How many of you have actually used telehealth? Wow, that's higher than I thought it would be. Interesting. All right, let's switch gears. The devil in the room, I want to talk about AI. How many of you have used AI at work? Pretty much everybody. Wow, okay, AI at work. Let's talk about AI in healthcare and kind of the gnarly ethical issues that I think pop up, at least for me, being in privacy. I'm always losing sleep at night about the juxtaposition of use of AI in healthcare. Ladies, what are your organizations doing about AI in healthcare, and how are your organizations balancing this great new technology, but also struggling or wrestling with the ethical implications of AI in healthcare specifically? I don't know who wants to take that first. Cami,
I can start. I am in a highly regulated industry. So I think our adoption of AI has been very slow for that reason. There is a tremendous amount of concern, for good reason, about privacy and making sure that we're not using any artificial intelligence that might somehow put our members at risk. There are a couple big areas and big opportunities for AI. One is clinical decision support. So we have care managers who stand at the ready to help our members coordinate care, help them explain medical conditions and things of that nature. And I think that there's an opportunity to use AI to sort of personalize those messages and make sure that we're getting the right information to the members in a way that they need and in a way that they can understand. The other big place for AI, which is very controversial, is in the prior authorization space. So there's a lot of attention right now being paid by states, by CMS, by lots of legislators in terms of prior authorization, which is a hurdle that providers oftentimes have to overcome in order to get a service paid for. So I may think that someone needs X surgery, but I need to demonstrate what we call medical necessity to the insurer in order to get that service paid for. Currently, that's a very manual process where there is a nurse that reviews the case. If the case meets criteria, she can approve it. Otherwise, it goes to a physician. The physician leverages their own tools and clinical decision making in order to render a decision. Potentially, AI could cut down on the amount of human resources that are needed in order to make those decisions. There's a lot of concern, though, about automating that and whether or not you're going to introduce bias, whether there's going to be consistency, whether there are going to be additional challenges there. So as an organization, we have been very, very conservative. But as a person, I'm excited about the possibilities. I think that we need to figure out how we put the right governance around it, how we have the right guardrails. And then I mentioned earlier that I'm particularly concerned about health equity, and there are huge equity issues involving the data that is foundational to AI and whether or not it is able to extrapolate and properly apply rules to diverse populations.
So the same as you, our system has been very slow, and I think, there's a lot of fear with AI. There's a lot of horror stories we've all heard. One of them I think was with the Eating Disorder Association. They had been using an open loop model, and very shortly after they implemented their chatbot, the chatbot started telling people that they should go on restricted calorie diets, which is exactly what you don't tell eating disorder patients. So there's a lot of fear there. Then I think on the flip side, looking at, building out, we talked about building out closed loop models, and I think my legal team at work hates me probably because I love to challenge them. And so we looked at, can we work with a company and build a closed loop model just on our data, which sounds great, until you, if your system is biased, then you're introducing bias. But then if you have an open loop model, they're suggesting things that you might not even have in your system, or they don't know that you have a lipid clinic and you have these specific providers that can treat the patient this way. So there's a really difficult juxtaposition, and we're also in a place where it's hard to know how and if we can monetize our data. So as we look to help a company build a model to do a specific task, we were going to build some generative AI. The legal team is like, I don't know that we can let them use our data to build this model that they can then monetize. And so there's still a lot of, we're still in this place where people don't know all the answers to these questions. And these are real struggles that we have every day of, what are you going to, if you have a system that uses the data of your customer, are you using it to improve your model, and is that legal? And how does that system feel about it? And so those are all things we're really fighting with still right now.
Yeah, I think it's a great point that people are still figuring out how to answer the questions. There's a whole bunch of questions on the table. And for our system, our CIO always says that we have had some successes and we've had lots of lessons learned in the space. So as an example, we're using generative AI to draft inbox messages, through MyChart. Those, of course, get reviewed by a human, but it's, gets you over the barrier of writing the first message, and then the provider can edit. We've rolled that out a fair amount, not completely across the hospital. And what we've found is different users like it more than others. And so, so far, nursing has adopted it far more readily than some of our physicians have. So that's a whole other area. What does this mean? What do we need to think about that? that's one. You mentioned ambient listening. We're also piloting that. That seems to have people very excited because it addresses some of these bigger issues. The physician can focus on the patient in a more human way, and they're saving time on the back end. Maybe the notes are better. We'll find out. That's part of the pilot, right? So those are examples of where we're trying, and that's on the generative AI side. There are many examples, probably in all of our systems, of plain old AI, if you want to think of it that way, but reading radiology images and things like that. So those are implemented in different ways. But for all of those, one of the things that we talk about all the time is what needs to be presented so people feel comfortable adopting the technology. How do you trust it? And it goes back to all these questions that we're all talking about. Do we trust the data that it was built on? Is the data that it was built on meaningful to our patient population? And so, being part of an academic medical center, there are a lot of research projects going on in our shop, not in my shop, but across the School of Medicine, to answer those questions. If we look at the whole population of Wisconsin to train this model, how does that look different from our Madison-based model? And when you're treating a Madison-based population, which one is more appropriate to use? I mean, these are real questions. Then the data monetization piece is a big discussion. So in the conversations I've been in, I've heard everything from the health system owns the patient record because we own the EMR, to no, the School of Medicine owns the patient record because we are the research entity. And that's a very accepted way to gain access to health data, is through research. So that's like, people can wrap their heads around that. And then other people say, no, the patient owns the data. So again, lots of, I would say, fundamentally unanswered questions. And then I always find myself in a bit of a moral dilemma too, because I'm a private person. I don't want my data out there, and I can see the promise if we all contribute data to some of these technologies and models. So it is a tough place. And I think the good news is the providers are asking those questions. Can I trust it? Does it make things better for the patient and the process? Patients are clearly asking the same things too. So I am optimistic about the path. It's just a lot of work ahead.
I want to touch a little bit on what you mentioned about trust, because I think that is huge, and I think that's a really important factor when adopting AI. And I think we touched on this when we talked together. Trust is very generational, right? So if you tell people of my parents' generation, for example, we're going to use AI to triage you and determine kind of initial steps and what you need, they would reject that at the door, right? Completely foreign to them. It's Star Trek. It's not anything that they're interested in. But if I tell a 21-year-old cousin, hey, we're going to use computer to try to do some initial things, and then we'll kind of have a human get involved later, they'd be like, okay, sounds good, right? Because their generation has grown up being highly dependent on technology, understanding technology, and feeling more comfortable with technology. So I think when we're thinking about how we begin to garner trust for these solutions, we have to recognize that the approach for one generation may be different for another generation. And then I think the same holds true for other populations. Speaking of, the Black population, for example, there's a very painful past with the healthcare system. So there may be a reluctance to adopt anything that seems as though it might introduce bias. So I think these are all things that we have to think through, how we get over these hurdles, who is the right messenger, right? So we may need to get community organizations, churches, different things to start talking about these things and start introducing these in communities and in other settings outside of healthcare so that they can be adopted later on.
Well, and I think you brought up an interesting point of people. There's a lot of data out there, but there's still a lot of data gaps, and things that we haven't gathered. If you're a certain person, we have lots of data on you. Right. Thinking a white 50-year-old male, we've done research on you for many, many years. But for us, we have the largest Burmese population outside of Burma. We have a huge Amish population. The Amish have some of the most interesting genetic diseases that you can imagine. So these models just aren't built with that kind of data. So to provide you with outcomes, they just don't have them. There's just not enough data for them to work. So there is always going to have to be some human intervention because there's just things that right now, still, the data's not going to pick up.
Absolutely.
We have 5 minutes left, and I know I have a lot more burning questions, but I want to get to what utopia looks like. My number one strength is futuristic, so I'm obsessed with the future. What does the future look like for healthcare in 5 minutes or less that looks like utopia? I don't know who wants to take that first.
Go ahead.
I think if we can treat the patients the way they want to be treated, where they want to be treated, there's a whole big push in Indiana about keeping the elderly at home, and they started that. That's the kind of work that we want to do. How can we give the patient the treatment they want, where they want it, when they want it, and keeping people healthy, moving to that value-based care model. We don't want to keep treating sick people. We want to get people to a place where we get them healthy and we can keep them healthy.
So I couldn't have said it better. I think my utopia is that we move away from sick care to well care and health care. So right now, I think in the US, we are really good at pulling people back from the brink, right? So we are second to none in dealing with really complex medical conditions, and that's something to be proud of. But what if we didn't have to do that all the time? What if we really put our effort into preventative health, into nutrition and healthy lifestyles? If you go to other countries, you will see that there's a lot more people walking and biking and doing things that foster a healthier lifestyle. Whereas here in the US, we're always in a rush. Our culture is such that we've got to get to places quickly, we drive, that leads to pollution and all of these other things. So I think healthcare for me is all the things we talked about, but it's also just kind of a cultural shift where we really focus on prevention, and maybe we can eliminate the need for some of this advanced healthcare technology and solutions that we have because we just have a healthier population.
Yeah, I love that too. I think the right care at the right time in the right place is a version of what we're all saying. And then to get a little futuristic, I get excited about the thought of a collection of data about me being able to inform that right decision at the right time in the right place. And then even just on a more personal level, like I dream of going to a doctor's visit and having them see something I haven't thought of already because of all, the bigger universe of data that could help inform a diagnosis or a decision. That to me is an exciting future state.
Yeah, personally, pharmacogenomics in our pharmacy nerdy world is super exciting. You can get a test for pharmacogenomics for yourself for under a couple $100, where it used to be thousands of dollars. I've literally handed that report to my personal physician, and I said, moving forward, if we have to go on some kind of therapy, I would love it if you could please, optimize it based upon my PGX profile. So I think there's lots of exciting things coming. I think to all of the panelists' point, there's a lot of questions still on the table, right? But the beautiful thing about healthcare is it's constantly changing. For the better or the worse, it's debatable, of course, but there's always something new, there's something innovative, and I want to personally thank all three of you ladies for pushing the envelope forward here in the Midwest when it comes to innovation in healthcare. We are grateful for your presence today, and thank you for your input during the session. So let's give them a round. Thank you so much.